I'm going to introduce someone that you're all very familiar with already, and she really needs no introduction, but she deserves all the kudos we can give her. Dr. Mimi Secor. She's a nurse practitioner, a national speaker, an educator, an international best-selling author, and a health and fitness advocate. She's worked for 43 years as a family nurse practitioner and was one of the earlier nurse practitioners who had her own practice, seeing patients up here in the Northeast. She's also a senior faculty with Advanced Practice Education Associates. She has a DMP from Rocky Mountain University of Health Professions and is now serving on their board of trustees. She's a fellow at both the American Association of Nurse Practitioners and the American Academy of Nursing. She's also published extensively. Most recently, she became a best-selling author with her newest book, Debut a New You, Transforming Your Life at Any Age, because she truly is a health advocate for all of us. She's passionate about helping people find their health, and especially NPs become healthy and fit. Please join me in welcoming Dr. Mimi Secor.
Thank you for joining me for Polycystic Ovary Syndrome Update 2022. Common, serious, and more complicated than ever. This is an exciting topic and one of my favorite topics, and especially today because we have so much new research and so many better ways to help our patients, particularly around management. So we're going to talk a lot about different aspects, and I'll get into the objectives here shortly. So I'm Dr. Mimi Secor. I'm a family nurse practitioner for over 4 decades. I specialize in women's health. I'm a national speaker, educator, author, and more recently in my career, fitness advocate. I'm senior faculty with the Advanced Practice Education Associates, better known as APEA. And I earned my doctoral degree later in my career from Rocky Mountain University in Provo, Utah. And I now serve on their board of directors, which is very exciting for me to give back to the university after such a great education. I have really taken my health and fitness to a different level than I ever thought I would, having been even a competitive bodybuilder. My last competition was in 2018, and I actually came in second place in the over 55 category. So I was really proud of that. I have 2 health and fitness books. One is on pre-launch. My most recent book is Healthy and Fit at Any Age, and you can actually pre-order that now. I absolutely have a passion for helping nurse practitioners, PAs, women in general, and literally everyone to get healthy and fit. I believe that it's really our obligation to be healthy role models so we can serve our patients better and also provide better care. So I have nothing to disclose other than what might be something I could disclose. I have no pharmaceutical conflicts, but I have had 3 holes in one playing golf. I just have a lucky game. And something else you might not know about me, I took up watercolor painting during the pandemic to reduce my stress level. And now I'm really, really into it. I always have a sketch in my brain. I always have something that I'm painting. I just love it. So our objectives for this session, we're going to talk about the epidemiology, the complex pathophysiology. It's really incredible. And the risks and complications we'll go through. So important for us to all remind ourselves about. The symptoms, the signs, the diagnostic workup, which is not cookie cutter. Every single patient you see is going to have a different diagnostic workup. And then we'll talk about best practice management and what you can do to really help your patients, both with medication and also non-medications. So we know this is the most common reproductive endocrine disorder in women, affecting up to 10% of women. There tends to be a genetic predisposition, so you'll see a familial tendency when you take a family history. Obesity is an independent risk factor, so we know that body mass index is increasing. It's estimated that by 2030, 50% of Americans will qualify as being obese. The lean variant of PCOS, we have less research on, we understand less well. That's about 10% of our PCOS population. And we know there can be a serious sequelae associated with this, including diabetes, heart disease, metabolic syndrome, infertility, various cancers, which I'll go through all of this, mental health problems. The list is ever expanding. So this is a serious cardiometabolic OBGYN ticking time bomb. That's one way to really think about it. We need to help these patients manage their symptoms, but also reduce their risks for these serious problems. And that's always in the conversation you're going to have with yourself and with your patient. So we now know that it's not just cysts on the ovaries. That's what we thought for most of my career. We now know this is an androgen excess disorder. involving the ovaries and the adrenal glands. And in most of our patients will be associated with insulin resistance. So we also know that the differential is very complex. There are certain conditions we need to rule out, certain conditions we see associated with PCOS, and I'll go through that with you. So what's new? This is the leading cause of menstrual abnormalities, in case you didn't know that. The exact cause is unknown. It may turn out to be multifactorial. They're even looking at in utero exposure, the exposure of the unborn baby to the mother's lifestyle, even the mother's eating habits. Kind of fascinating area of research. Insulin resistance affects a whopping up to 70% of women with PCOS. And interestingly, and this is going to come up over and over and over, insulin stimulates ovarian testosterone. So if we can get the insulin resistance under control better, that's going to help lower testosterone. It's going to improve the patient's symptoms, because the elevated testosterone is really what's causing the hyperandrogenism symptoms we know so well, acne and abnormal hair growth. There also is a correlation with inflammatory markers, a host of inflammatory markers, C-reactive protein, tumor necrosis factor, interleukin 6, interleukin 18. We know those inflammatory markers are more pronounced when patients have obesity, particularly abdominal obesity. So this is a condition that commingles with other very concerning conditions. So when we look at the symptoms, oligomenorrhea, however you say it, potato, is highly predictive, meaning irregular cycles. And these patients will often tell you, since I started my periods, I've never known when I'm going to get my next period. Sometimes I skip a month, sometimes I have 2 in a month, highly predictive. Hyperandrogenism, also very predictive. Hirsutism and acne. Usually teenagers grow out of it, but these patients don't. They can tend to have very steady symptoms or even worsening symptoms. Obesity, common. Infertility, very much a big problem. That's why we don't want our PCOS patients waiting till they're 35 to test their fertility. We want them having their babies younger. Abnormal uterine bleeding. If they have irregular cycles, that means they don't ovulate every month. And if you don't ovulate every month, you can have an overgrowth in the lining of the uterus, which is what we call hyperplasia, which can go on to develop atypia, which can go on to develop uterine cancer. So this is something that we need to manage for patients so they're not at risk for abnormal uterine bleeding or uterine cancer. 3-fold increased risk for uterine cancer, increased risk for breast and ovarian cancer, and several other cancers we'll talk about shortly. So we talked about how cardiometabolic conditions are associated with this, and also hyperlipidemia. So you're always going to check lipids somehow, even if they don't have health insurance, check some aspect of the lipids. And mental health problems. These patients can have a host of different mental health problems. We used to think we're in response to the distressing symptoms, but now we know these patients are kind of hardwired for a risk of mental health problems. So you're always going to screen your patients carefully. So, and also even screen them for eating disorders and issues around food, because often these are the same patients that have a really hard time losing weight. And this is the time of year when we're always talking about resolutions and people always seem to want to universally lose weight. So counseling our patients is really important. So menstrual irregularities, classic clinical profile. Patients will say to you, I've never had regular periods. And often I only have a few periods a year. 6 or fewer menses per year is in quotes because they may be dysfunctional uterine bleeding episodes, abnormal uterine bleeding episodes. They say to you are periods, but they're not. We'll talk about how to distinguish those two. They may have regular cycles. Those patients are less common, and they may actually have a more complex differential. So we'll talk about that more too. So I used to have patients back in my early career that would come in and they'd have done their homework at the library, and they would write down, gee, do you think I have Stein-Leventhal syndrome? That was the first term for this condition when they thought back in the 1930s, 40s, 50s, 60s, 70s, they really didn't figure out the underlying problem of insulin resistance till pretty recently. Thought it was just a problem with cysts on the ovaries. So let's look at a case. This is from my practice, but it could be from your practice, and it's kind of classic. So this patient, 30 years old, comes to you. She says she took oral contraceptives in the past, seemed to be okay, had some side effects, but doesn't even really remember what they were. Gets 3 or 4 periods a year. Your red flag should be going up already. That's very irregular. She's been irregular since 12 years of age. She's been married a year, but at age 30, she doesn't want to have a pregnancy yet. That should also raise some red flags in your brain. Because remember, PCOS patients shouldn't wait until age 35 to test their fertility because they're at greater risk for fertility problems anyway. So these patients are best suited to have their babies in their 20s. So we need to educate her. Both parents have diabetes and are overweight. So she has a cardiometabolic endocrine family history. So what we know about the pathogenesis and pathophysiology of PCOS is that insulin resistance and hyperinsulinemia drive the production of androgens, most notably testosterone, which causes menstrual irregularities and also causes hyperandrogenism. And when you have an increase in testosterone, that makes insulin resistance worse, and that's the cycle. That's the cycle. You improve insulin resistance, you're going to lower testosterone, and you're going to improve the symptoms of PCOS and also lower the risk of the sequelae, the complications. So insulin resistance plays a really critical role in the development of symptoms, in the persistence of symptoms, in chronic anovulation, and in cardiometabolic risk. As we know, patients that are diabetics have insulin resistance and they're at high cardiometabolic risk. So what we also know is that androgens are increased, estrogen levels are increased, and that causes a breakdown, a malfunctioning of the hypothalamic pituitary ovarian axis. So the whole connection between the brain and the ovaries is disrupted by these abnormal hormone levels. And what we also know is these abnormal hormone levels thicken the ovaries and also continue to increase testosterone. The thickening of the ovaries, though, is really important to keep in mind. So on the left-hand side of this slide is the very complex orchestration of the hormonal ebbs and flows of a normal menstrual cycle. On the right, you notice that basically the hormones are flatlining. They're slightly elevated, but they're flatlining. There's no way to ovulate in a situation like that, but that's what we see in patients with PCOS. So it's a significant derangement in the normal physiology into this really abnormal pathophysiology. And that's why it makes it hard for patients with PCOS that's not managed to get pregnant and stay pregnant. So what we end up with are these elevated levels of hormones. We call them tonic because they stay elevated in the female hormones. And what we also know is that new follicles are constantly stimulated because the levels are slightly elevated, but they don't mature because of the plateauing of those hormone levels. So we have rare ovulation, we have insulin. Remember, testosterone elevation drives insulin resistance. That thickens ovarian tissue. And then insulin suppresses programmed cell growth. So you have more thickening of the ovaries. If you don't have, I love this word, apoptosis. If you don't have programmed cell death, you're going to have a buildup of cells in the ovaries. So that's what produces the string of pearls, the cysts in the ovaries. So hence polycystic ovary syndrome develops, and it is a vicious cycle. So this is the classic string of pearls. So you see the cysts in the ovaries, and they look like a dark string of pearls. That's classic. So we also know cancers are associated with PCOS. When we look at chronic hyperandrogenism, there's an increase in conversion of androgens in fat tissue to estrogen. And that estrogen then stimulates the uterine tissue, also causes anovulation, which increases the growth of the uterine tissue. Remember, progesterone that's produced from the sac the egg comes out of when patients ovulate balances the uterine lining. When you don't have that happening every month, the uterine lining can thicken. That's what we call hyperplasia, which can over time, usually over many years, lead to abnormal cells, atypia, and even cancer. So that's another mechanism related to anovulation. And then there's an increasing risk because of these factors that increases risk for uterine cancer, breast cancer, ovarian cancer. So you have an elevation in estrogens from adipose tissue, then you can have an increased risk of these cancers. So what we also know about pathophysiology related to hirsutism is that hyperinsulinemia, insulin resistance, drives this also by lowering sex hormone binding globulin levels, which drives up testosterone And that increases alpha reductase at the cell level, at the skin cell level. And what that allows is for testosterone to be converted to the potent form called dihydrotestosterone. If you can lower testosterone by raising sex hormone binding globulin levels, which is what combination birth control pills do, then you're going to improve symptoms of acne and abnormal hair growth, because they're not going to be able to convert testosterone to dihydrotestosterone as much if their testosterone levels are lower, because you've given them combination birth control pills that raise sex hormone binding globulin levels. You give them metformin, that's going to improve their hyperinsulinemia, their insulin resistance. That's going to drive down testosterone and help with the symptoms. You give the two together, you're apt to get even more bang for your buck. So sex hormone binding globulin level is a new marker for predicting polycystic ovary syndrome risk. And this was a systematic study that was published in 2018. So it's relatively new, looking at a huge number of studies, but not that many PCOS patients, finding a correlation between lower sex hormone binding globulin levels, inversely increased testosterone, and increased risk of polycystic ovary syndrome. So we know low sex hormone binding globulin levels plays a role in the signs and the development of the signs and symptoms of PCOS. By increasing sex hormone binding globulin levels through giving birth control pills, we can increase that sex hormone binding globulin level and help patients. So that's a fascinating area. Polycystic ovary syndrome is also linked to the gut microbiome. Really very new research also. And what they have found, and you may or may not have heard about this, that androgens affect the gut microbiome in a negative way. The higher the testosterone, the less diverse is the GI microbiome. So these changes, we think, may influence how PCOS develops. We definitely need more research. This is preliminary, so we can't come to any absolute conclusions, but it is a fascinating link. So this is an image that's really helpful in patient teaching. It just shows the interplay of everything that we've been talking about. And I use it with my patient teaching. You can use it with your patient teaching. It's just a very, very helpful image to help explain all this complexity to patients. So you have back to your 30-year-old patient. So what are we going to do for a workup? That's $1 million question. So let's figure out how we make the diagnosis. First of all, the diagnosis is a clinical diagnosis. You can do this in primary care, and it's based on Rotterdam's criteria. So 2 out of 3 criteria. And that's basically irregular cycles, hyperandrogenism. They don't have to have both. They can have an acne or hirsutism, sometimes or male pattern balding, sometimes central obesity. Ultrasound is not necessary. If it's in your wheelhouse, great, but it's not necessary because you have 1 and 2 out of 3 criteria. So there are other different definitions that are used by various organizations, but by far Rotterdam criteria is the most common. So back to our classic string of pearls. You don't have to check for that on ultrasound, especially if you're working in primary care. So, and speaking of ultrasound, the younger the patient, the less likely we're going to see the string of pearls in that patient. And in fact, the younger the patient is, the more likely they may have some mimic condition, like late onset congenital adrenal hyperplasia. And I'll talk about how that can present. But just know, they tend to have more regular cycles. And if you're thinking, gosh, do I have this patient that has this kind of problem? Refer them to reproductive endocrinology. You can start with OBGYN, but I can pretty much assure you they're probably going to refer the patient to reproductive endocrinology. So be a little careful diagnosing teenagers. See if they kind of work through this on their own. Or if you're really worried because you've got a teenager and they have regular cycles but major acne and abnormal hair growth, no problem sending them to endocrinology. So the diagnosis, clinical presentation is sufficient if they don't have virulizing symptoms. Rapidly virulizing symptoms are worrisome because you have to worry about a virulizing tumor. We'll talk about that shortly. So you're going to definitely have to think about, what do I need to consider in terms of labs? Now, you may look at this slide and go, holy cow, this is too complicated, but you're going to check vital signs. You're going to check a pregnancy test. If you have a patient with PCOS, often they're risk takers. If they don't get their period every month, they may not think they have much to worry about. So be very careful to rule out pregnancy and educate the patient. CBC, we're going to talk more about this. These patients are at risk for both anemia and iron overload. Kind of fascinating, new area of research. Thyroid problems, TSH, you're definitely going to check because if the patient has hypothyroidism, that can actually cause cysts on the ovaries. So you're going to want to do that. And even if they don't have health insurance, figure out a way to check some aspect of their lipids. You're going to check some way of screening for blood sugar. And you can pick fasting blood sugar, random glucose, hemoglobin A1C, and you're going to look at the results and figure out, am I worried about these patients? If any of these are abnormal, then you're going to do an oral glucose tolerance test. The American College of Obstetricians and Gynecologists recommends this as the gold standard because it's the most sensitive and specific. Testosterone levels, you don't have to worry about unless the patient has good health insurance or if they have rapidly virilizing hirsutism. Say they come to you and they say, oh my God, look at the hair on my chin. This just happened in the past month and a half. Then you have to check a testosterone. It may be modestly elevated in PCOS, but it shouldn't be triple digit. If it's triple digit, you need to refer them to endocrinology ASAP. Prolactin level. We're not sure if a slight elevations in prolactin may be associated with PCOS, but definitely if it's significantly elevated, you need to rule out a prolactinoma. Again, refer to endocrinology is what I would recommend. If they have a headache, vision changes, breast discharge, then you have to check prolactin level. LH-FSH, it's not a good test. It's not highly sensitive or specific, and it's expensive. So if they don't have health insurance, don't waste your time. If you're thinking about adrenal hyperplasia, you're thinking about Cushing's syndrome versus Cushing's disease, you probably ought to refer the patient to reproductive endocrinology because even for them, it can be challenging. So it's something that if you're sort of thinking about, you probably ought to refer them. Ultrasound, remember, it's not absolutely essential for diagnostic criteria. Diagnoses of exclusion. We talked about thyroid, hyperprolactinemia, non-classical congenital adrenal hyperplasia, Cushing's. They're uncommon, but definitely you always have to be thinking about the whole list of differential diagnoses. So thyroid problems, if they have primary hypothyroidism, that increases risk for ovarian cysts. By improving the hypothyroidism, you're going to decrease sex hormone binding, you're going to improve sex hormone binding globulin levels and improve free testosterone. So generally the whole, what might have looked like PCOS is going to improve with management of hypothyroidism. So I think that's fascinating. Prolactin levels, that's still an active area of research. It may be an integral part of PCOS, but if it's really absolute, very high, very elevated, then that may be a prolactinoma, and you have to really think about that. So obesity and the risk of anemia and iron overload. This is new research. Anemia is related to pro-inflammatory cytokines that increase hepcidin that inhibits absorption of iron in the intestinal tissues. Enterocytes are the absorptive tissues lining the intestines. Iron overload is seen much more typically in obese patients with PCOS. It's driven by insulin resistance. That's what IR is, insulin resistance. So you may see either or. Fascinating, fascinating new area. Excluding late onset non-classical adrenal hyperplasia generally presents in adolescence or later. Very uncommon. They have more regular cycles, as I mentioned, and you want to refer these patients because it can be a challenge to figure out this versus Cushing's syndrome versus Cushing's disease. Generally differences for Cushing's syndrome and Cushing's disease. They may have wide purple striae. They may have easy bruisability. Posterior cervical fat pad, we kind of call the buffalo hump, round puffy face, muscle wasting of extremities. That's kind of an extreme profile. But generally, unless you're working in endocrine, refer to endocrine. That's your best action. And remember with cancers, that this is just really important to think about increased risk for endometrial, breast, and ovarian cancer. So when we think about abnormal uterine bleeding, always be thinking about all the differentials, but also remember that postmenopause is a uniquely high-risk time, particularly for polycystic ovary syndrome patients. Even one drop of blood after they've gone 12 months or longer, which is the definition of being postmenopausal, they must be referred to OBGYN for a workup to make sure they don't have uterine cancer because their risk is 9%. And this is relatively new research. So you're not going to let them say to you, oh, if it happens again, I'll come back. It was just a little bit of bleeding after I had sex. And you can certainly look down there, make sure you don't see a source of bleeding in the vulvar area, the vaginal area. If you see a source of bleeding on the cervix, best to refer to OBGYN. This is the PALM coin acronym, the nomenclature, to remind you about the differential diagnoses of abnormal uterine bleeding. I just decided to add it in, even though we're talking about polycystic ovary syndrome. So the palm portion, just think about putting a coin in the palm of your hand and you'll never forget palm coin. The palm portion are structural problems like polyps, fibroids, scarring in the uterus, malignancy. The coin portion are non-structural, like factor V Leiden disease, an example of a coagulopathy, ovulatory and endometrial problems, medications we give, notably thyroid medications sometimes can cause abnormal uterine bleeding, and non-classified, just sort of everything else. So endometrial biopsy is not based on age when you should perform it. So it's the exposure to unopposed estrogen. So say you see a patient, they're 35 years old, they've never had their polycystic ovary syndrome managed, maybe because they're undocumented. Maybe they're an immigrant from another country and didn't have any health care where they lived. So they could be at risk of uterine cancer even at a relatively younger age if they didn't medically have their PCOS managed well over time. So PCOS is high risk due to anovulation. Remember, ovulation produces the ability to protect the uterine lining with progesterone, which is produced by the little sac, the corpus luteum sac, the egg comes out of. So if you don't ovulate, you're not going to have that protection built in. So keep a low threshold in your mind. Don't always think about age. Don't trust an ultrasound. Refer the patient for a workup by OBGYN to make sure their uterus is okay. So ovulatory versus anovulatory. With ovulatory bleeding, they get premenstrual something. Usually patients have some sense of they're going to get their period, some way they feel. There's a pattern. And the bleeding pattern is pretty consistent from one episode to the next. With anovulatory, bleeding comes out of the blue. There's no pattern. Every episode of bleeding is different. So that's the difference. And what you want to make sure of is that you work with the patient to look back at the past year and figure out how many ovulatory bleeds did they have. If they had at least 4 to 6, they're probably pretty okay in terms of lower risk for uterine cancer. If you can't even document that many cycles, they're at high risk for uterine cancer, especially over many years. How many years, you say? Well, probably at least 5 years, but I don't want to say that absolutely because it's possible that patients could be at a higher risk for uterine cancer with less than that time frame going by. So here we have a patient with, you're performing a very challenging GYN exam. Sometimes they're very challenging. So be glad you're not in veterinary medicine with large animals. I think it's kind of entertaining. So I thought I'd throw it in there for a little levity. So ultrasound results are not based on age. Generally for reproductive age, the endometrial stripe shouldn't be greater than 10 millimeters. And there is even a cutoff of 8 millimeters or more than 8 millimeters. In menopause, greater than 4 millimeters is considered abnormal. So just FYI, it really depends on the reproductive age, when in their cycle that you're checking the endometrial stripe. And that's the uterine lining. The endometrial stripe this is the uterus, the outline of the uterus, and it's the inner lining. So it's the endometrial stripe is this portion here that goes around in sort of a pear shape. All right, so abnormal uterine bleeding, manage it. Give a progesterone challenge if they've been 6 months or longer. They should bleed within 2 weeks. And if they don't bleed, we give a combination hormonal contraceptive. If they don't bleed within a few weeks, then we refer to reproductive endocrinology, if that's all you have around. And they're going to evaluate whether the patient's okay or not. So back to our case study. We've got this patient with an abnormal BMI, waist circumference over 35, which in females we want under 35, combination oral contraceptive withdrawal bleed. So that means that the pituitary hypothalamic ovarian axis is ready to go if we medically manage the patient. HDL is low, LDL is trending higher, triglycerides trending higher, fasting glucose trending higher. So we have the absolutely normal under 100, and we have sort of pre-diabetes. And we also, we just need to know that this patient is trending toward being high risk. So what do we want to do? Do we want to do more labs? Do we want to do give metformin, combination contraceptives, advise her about earlier pregnancy than waiting. Definitely, she's a woman of reproductive age. She needs to be on folic acid. Every woman of reproductive age, at least 400 micrograms. That's what CDC recommends, 400 micrograms. Once they're documented to be pregnant, how much? 1,000 micrograms, which is equal to 1 milligram. All right, so how are we going to manage the patient? We're going to manage the menstrual problems. We're going to manage the symptoms. We're going to help manage the obesity, the infertility issues, the mental health problems. We're going to prevent complications. So we've got our hands full. These are labor-intensive patients if we're doing a great job. So we're going to talk with them. A team approach is ideal. Now, you may be the team. The more isolated the more remote your practice is, the more you're likely to be wearing multiple hats. But in an ideal world, we have multiple specialists helping us. So what we want to do is think about contraception versus conception. Contraception meaning medical management, conception meaning, facilitating earlier pregnancy than waiting too long. So that's what we mean by fast tracking fertility. So prevention is key. We want to make sure we really deal with all these different aspects of managing the patient. And that takes time. It really is, like I said, a labor-intensive condition to manage if you're doing a great job. So we're going to exclude other conditions. We're going to give symptom relief. We're going to work on a healthy lifestyle with patients. Remember that if you're walking your talk as a healthy role model, that has a very powerful effect on patients. Very powerful. I say it's the most powerful medicine we have to offer. Medical management, we'll talk about obesity control, easier said than done. I just usually recommend patients start making healthy choices that they can live with. A nutritional plan, you can never go wrong with a Mediterranean eating plan. You probably already know a lot about the diabetic eating plan. That's an excellent one too. Mental health care, critical. Prevention of complications, critical. So PCOS and pregnancy risks, it's sort of referred to as a ticking time bomb. The earlier in their chronologic age, the better in terms of getting pregnant if it's going to work in their lifestyle. So they're at greater risk for all kinds of problems in pregnancy. And all these problems go up with age and they go up with body mass index increases. So that's the problem. A lot of times these patients are already overweight. They may be older when you see them for the first time. Older meaning in this context, 30 or above is older in this context. 35, definitely they should have had their babies by 35. But who tells them that? We need to. So your mantra is going to be contraception, meaning medical management, versus conception, meaning fast forwarding pregnancy. So when you have a dress made entirely out of condoms here, remember, if you start making changes with the patient around healthy lifestyle changes, they could suddenly become fertile. And if they're not ready to be pregnant, then that could be a problem. So always tell them that with just a little bit of weight loss, they could start ovulating on a regular basis. So that's critically important. So lifestyle changes can improve insulin resistance a whopping 50%. So weight loss, dietary changes, exercise, all have this incredible benefit. And it doesn't have to be dramatic, just consistent. Combination hormonal contraceptives, you're going to utilize low androgen, meaning you don't want the progestin in the combination contraceptive to make the acne and the abnormal hair growth worse. So the three that are most anti-androgenic are levonorgestrel, norethindrone, norgestimate. Now you may be thinking, gee, I thought drospirenone was anti-androgenic as well. It is, but it's slightly more risky in terms of risk of complications. So I tend toward levonorgestrel, which has been found to be the safest progestin in combination pills, followed by norethindrone, norgestimate. Levonorgestrel has the lowest breakthrough bleeding rate, which I like. Insulin sensitizers can be very helpful as well. Start low, go slow. By improving insulin resistance, which happens when we give metformin, that's going to help with lowering testosterone, which is going to help with symptoms. So you're getting at helping with the symptoms a different way with combination hormonal contraceptives. Remember, that's going to raise sex hormone binding globulin levels, driving down testosterone, improving insulin resistance. Both do that. So it's just kind of a different set of steps. And sometimes we give the two together when we need a little bit more bang for our buck in terms of symptom relief and management. So remember, a little weight loss goes a long way in helping patients to reverse their symptoms that they're having. Weight loss. Sometimes bariatric surgery can help, and we're finding more research on various other medications for prediabetes and diabetes, particularly the GLP-1 agents. Semaglutide was just approved, as you know, for weight loss. So that's another option. Promoting weight loss, improved insulin resistance, reduces cardiovascular risk, so many positive benefits. However, the GLP-1s have not been found to be safe in women of reproductive age, whereas metformin is safe. It's safe if they're conceiving, it's safe during pregnancy. So always be aware of that. So when we look at a systematic review that looked at dietary changes, they found that low carb, low glycemic index really helped insulin resistance the most, really helped the cardiometabolic situation the most. Low glycemic index improved quality of life, high protein improved depression, self-esteem. So we really want to be thinking about quality nutrition and helping patients around their eating habits. If they're not desiring pregnancy, combination therapy, we can give contraceptives first line, that's typical. And then if combination hormonal contraceptives are contraindicated, we can use depo, medroxyprogesterone acetate. We're not sure long-term if that aggravates insulin resistance, so we just have to kind of be aware that that research is ongoing. Intrauterine contraceptives such as Mirena and Kyleena can protect the uterine lining by containing levonorgestrel, so protecting the uterine lining from developing uterine cancer, if that has to be one of your goals. And insulin sensitizers, sometimes we add those on, as we talked about. There tends not to be weight loss until you get into the higher doses, as you probably know. This is another dress made entirely out of condoms. It's kind of gorgeous. I think that should be at every prom in the world. People can take their protection off the dress as they leave the prom. I'm just kidding, but if they're not desiring pregnancy, combination hormonal contraceptives have a host of benefits. So they help with irregular cycles, acne, abnormal hair growth. They help induce withdrawal bleed. They don't cause ovulation. They induce withdrawal bleed. So patients may think it's their period, but it's not. This prevents uterine cancer by protecting the uterine lining. Remember, by giving a combination with estrogen and progesterone, you're protecting the uterine lining. You're suppressing T by what? By reducing sex hormone binding, by raising sex hormone binding globulin levels. You're driving down testosterone. So that's awesome. And that then improves insulin resistance. So the way combination hormonal contraceptives help with insulin resistance is kind of indirect. Whereas with metformin and other agents, you're going right after the insulin resistance. So remember, you're raising sex hormone binding globulin levels with combination hormonal contraceptives, driving down testosterone. So may even improve cardiovascular risk as well and cardiovascular events. So PCOS, progestin-only methods, depo may be, is probably safe short-term, but maybe not so beneficial over time because we don't know the impact of high-dose progestin on insulin resistance. So that's an ongoing area of research. Levonorgestrel intrauterine contraceptive, like I mentioned, protects the uterine lining with minimal systemic benefits, so systemic levels. So that's an advantage if that's what one of your goals, which it has to be. Etonogestrel implants, low systemic levels, probably okay, probably doesn't aggravate insulin resistance. That's still ongoing research. Metformin does a lot of different things, but remember, it primarily improves insulin resistance and raises sex hormone binding globulin levels, improving hyperandrogenism. So if you improve insulin resistance, you drive down testosterone by raising sex hormone binding globulin levels. You also reduce cancer risks, and this is dose dependent. Metformin also protects vascular endothelium, and that's pretty fascinating through a mechanism that's referred to as pleiotropic effects. So if you look at the blue at the bottom of the slide, vascular dilation, suppression of inflammation, reduction in C-reactive protein, all happens from giving metformin. Reduces cancer risks, and not only endometrial and breast and ovarian we talked about, but colon and hepatic cancer possibly as well. So we're looking at 5 different cancers that may be improved with medical management of polycystic ovary syndrome. It's pretty fascinating. So metformin versus combination hormonal contraceptive. This was a systematic study looking at over 170 studies didn't have many actual numbers when they actually boiled it down to the highest quality studies. So they referred to the data as very low to low quality. So we can't make too many conclusions from this, but we know that oral contraceptives probably offer superior control over menses and acne, whereas metformin probably reduces body mass index the best, decreasing abnormal blood sugar levels, lowering LDL. Neither are superior for hirsutism, lowering triglycerides, or increasing HDL. That's why often the two are given together to get the most benefit from the dual agents. And you'll see that in clinical practice. So speaking of hirsutism, just a good example. And it looks like there's some ethnic involvement here as well, because some ethnic groups have more hair, more noticeable hair on their bodies. So hirsutism, you want to think about referring patients if it's severe or persistent. You're going to try combination hormonal contraceptive. You're going to give it a good chance, 3 months, 6 months, sometimes even longer. Possibly give insulin sensitizers like metformin in combination. Spironolactone can be very helpful, but it is category C in pregnancy, so you better make sure they're using good birth control. And the magic dose tends to be about 100 milligrams twice a day, that for really persistent hirsutism. Finasteride is category D. It's 1 milligram a day. Eflorothin is a topical that's very expensive, can be helpful as well. When we look at Vanica, which is the brand name for eflorothin, is a hair growth retardant, and it can be very helpful. But again, if they're a woman of reproductive age, be careful. Finasteride, even more so, category D. And what it does is it inhibits 5-alpha reductase at the skin level. So there isn't as much conversion of testosterone to the potent form dihydrotestosterone. So that's how that helps. Remember, there are side effects with these medications. And remember that anytime you're prescribing off-label, which is finasteride, it's off-label, you're potentially jeopardizing your prescribing ability. So stay on label as much as you possibly can, particularly as a new graduate, but really over time, you want to be super careful, because if patients have a really negative outcome and it was an off-label prescription, you're kind of hanging by a thread. You better make sure your malpractice insurance is paid up. So there also was new research looking at vitamin D, polycystic ovary syndrome, and obesity. This was a systematic review that looked at over 1,500 patients with giving vitamin D supplementation, especially during the winter months, and reduced insulin resistance in polycystic ovary syndrome patients and improved mental health. So remember, you don't absorb vitamin D from a latitude north of Atlanta, Georgia, from November through May. And vitamin D is essential for so many different functions of our body. So this is not a surprise to me. So you might think about making sure patients are taking a vitamin D supplementation, probably at least 1,000 international units a day in those winter months. Some patients benefit from higher doses. Do you have to check levels? Maybe, maybe not. That's quite a controversial area. Cardiometabolic benefits were also looked at in this study of infertile women, only 40 patients, so it's very preliminary. They gave 50,000 international units weekly for 8 weeks, and they found beneficial effects on insulin and lipid metabolism in these infertile patients. So be sure that there's more ongoing research in vitamin D, but it may be a consideration to think about with your patients. Certainly, if they live at that higher latitude, even if they don't have PCOS, you probably want them taking supplementation. Menopause and PCOS, we really don't have much research on it. We just don't. But you have to be thinking with these patients that they may have subclinical cardiovascular disease because they're high risk for the development of cardiovascular disease and diabetes because of having PCOS. So you're going to think about if they are having moderate to severe hot flashes, it is thought, because of the most current research, that transdermal is probably safer. And so you want to think about the transdermal option, and it should be within 10 years of final menstrual period because it's safer then. But remember, some of these patients in early menopause, that's defined as within the first 10 years of last menstrual period, which is called final menstrual period, they may have subclinical cardiovascular disease already. So any estrogen may be high risk for these patients. If they have a uterus, you want to protect the uterus. The bioidentical option would be Prometrium. That's FDA approved bioidentical option. Remember, there is progesterone over the counter, but it's totally unregulated and not necessarily safe and poorly absorbed through the skin. So not recommended by the North American Menopause Society, where you should get your evidence-based information on managing postmenopausal patients. And their website is menopause.org. Super simple and easy to remember, menopause.org. So vaginal symptoms should be managed with vaginal estrogen if they're having issues. Moderate to severe hot flashes can be managed with systemic estrogen. Most safe, we think, is transdermal, not oral. There is a newer option called Bijuva. That's the brand name. It's a combination of natural estradiol and natural progesterone. That is an oral option, though. And the problem with oral options is if they don't get symptom relief, we have to go up in dose because of the peaks and troughs. So we have to keep going up in dose. Whereas with transdermal, you can give a very low dose and it gives very steady blood levels. So another advantage to transdermal as a route of delivery. So vaginal symptoms, vaginal estrogen is very safe. We have a new study from the Nurses' Health Study, huge study that found no increased risk of uterine cancer, breast cancer, or ovarian cancer. And also, no increased risk of cardiovascular disease. So critically important. We also have a non-estrogen serum called ospemifene, brand name Osphena, that can be utilized. Progesterone is a hormone metabolized into estrogen in the cells, but doesn't circulate as estrogen in the systemic blood circulation. So that is thought to be maybe an option for patients that have a higher risk for cancer. It's being looked at now in research studies. We can't say that that's absolute yet, so don't jump on that bandwagon. Remember that vaginal estrogen is very, very safe, even for patients that have a history of cancer. It's just a hard sell. Pelvic PT, an option for patients that are having deep pain with intercourse in general, and they haven't responded to estrogen or other modalities, can be a huge helpful area of management. And how do you find a pelvic PT? You just go to the American Association of PT to find a women's health specialist, and the website is apta.org. All right, so if they have superficial or deep dyspareunia that doesn't resolve with vaginal estrogen, you should definitely be thinking about pelvic PT. So once patients have pain with intercourse, and it doesn't respond quickly, they may be very, very reluctant to try to have sex again. So remember that with patients that have PCOS, there's so much you can do. Prevention is the key. Excluding other conditions like we talked about. This is a complex differential that you're going to have to think about. And symptom relief is critical. Lifestyle changes, just start with something very minor. A small change consistently implemented can make huge changes over time. Don't just pile all kinds of suggestions onto patients because they're only going to be able to latch on to one thing. And once they really get that automated, then you can start the conversation over what do you want to work on now and get that automated, get the patient really comfortable with that change. And then ask them what do they want to work on next. I think sometimes we overwhelm patients with too many suggestions. Remember to let the patient guide the conversation. What are they really committed to working on? How can you help them? What kind of support do they need? What kind of accountability do they need? There's so much you can do as a coach in primary care and not just spewing information to patients. So, revamp your motivational counseling, take a coaching course, just learn how to do that. You're going to give them a nutritional plan. You're going to make sure their mental health is good, that maybe they need a therapist. Maybe they just want to talk to you when they come in. Prevention of complications is key. So this is a complicated condition. It's one that you can really make a big difference in the lives of your patients that have PCOS. I want to thank you for your attention, and I really look forward to taking your questions. Thank you, everybody.
Thank you, Mimi, for such a fantastic presentation. We've had some great questions from the audience.
Awesome, that's great.
Yeah, so we will get to these. One of our first question was, can you explain a little bit why an IUD or rods or depot don't increase a risk for uterine cancer?
You mean the protection? The protection? So an
Correct.
intrauterine contraceptive that contains levonorgestrel, either Mirena or Kylena, protects the uterus because you're giving the progesterone that the uterus needs. So remember, when you don't ovulate, you don't produce progesterone, which balances the uterine lining. When estrogen is the only hormone stimulating the uterine lining, it can overthicken, and that can develop into atypia and cancer. So it's really important to protect the uterine lining in patients that are not ovulating on a regular basis.
Okay, that makes sense. Thank you for that.
And the implant doesn't provide that protection to the uterine lining, so it's not as effective as the intrauterine contraceptive.
Okay.
And there was something else, the patch. The patch is a combination, so it would provide protection by, just like the combination hormonal contraceptive. If it's a combination birth control pill or a combination contraceptive method, it's going to contain a progestin, which is going to help with protecting the uterine lining.
And the same would then go for Depo, Provera?
Depo is preventing ovulation. It's thinning the uterine lining. So it's kind of a different mechanism, but it is helpful in reducing the risk.
Okay, no, that's very helpful. Thank you. One of our participants noted that their problem with progesterone only is low estrogen causing vaginal dryness. So how can we encourage keeping the lining thin and managing dryness and sexual encounters for women who are
If you're using a mini pill, if you're using a pill that just contains a progestin, then that can be a problem. And sometimes even a little bit of local estrogen can help the vaginal area. And we know that it's super safe, and it's something that you could use in women of reproductive age.
Okay, thank you. What about, how do you feel about checking estrogen and DHEA levels in PCOS? Do you ever do it? Is it necessary?
It's really not recommended. If you're getting into DHEA testing and complex hormonal testing, it is recommended to send the patient either to OBGYN, which they may or may not have more knowledge than you. My preference is to refer to reproductive endocrinology, because even for them, it can get very challenging. In a teenager, do they have late onset congenital adrenal hyperplasia? That can be challenging. So I think unless you're a super expert in endocrine, you really need to send these patients out of primary care.
Yeah, that DHEA and interpreting the levels
can all get very complicated.
Yeah, it can. So in follow-up to that, for a patient with 3 to 4 periods a year, yet all their hormone levels are within normal limits, testosterone, prolactin, estrogen, and no other signs and symptoms of PCOS, do we do any other tests to work them up? What would you recommend?
I think that's a complicated situation, and it's one that I probably would refer out of primary care again, because I don't know the context. Are they obese? Do they have diabetes? Do they have pre-diabetes? You know, what is going on that they're only getting 4 periods a year? And that probably is going to require, again, reproductive endocrinology. It's way beyond the scope of primary care.
Okay, appreciate that.
Often I go directly to reproductive endocrinology because they're the experts on endocrine and women's health. And often they're in infertility centers. So you need to be very careful that you're explaining to the patient, you're not thinking they're infertile. You just want them to have the best expert to figure this out. Yeah. And remember that usually patients get regular monthly cycles within 2 years of starting their period. So we give about 2 years for the pituitary, hypothalamic, ovarian axis to kind of get in synchrony. So I think that's really important for clinicians to remember.
Yeah, no, I appreciate that. We did have one audience member who actually had a contraceptive question as well in relation to all this, that they're seeing a lot of young women, and the first choices that they're given for birth control are Depo or Nexplanon, and they're seeing weight gain, or the patients are already obese. And because that's a challenge in healthcare, are there other choices that might not have as much weight gain? Would we use them in our PCOS patients?
I'm such a huge fan of the intrauterine contraceptive, and now we have one for the nultiparous woman who hasn't had babies yet. It's really important. That's the Kylena. So it's a little bit smaller, easier to insert. And remember, we're in the context of patients having fewer and fewer options if they have an unplanned pregnancy. I don't think that even needs explanation. So I think that we're in a crisis with making sure our patients have a real foolproof method of birth control, especially teenagers and young women. So I would just beg you in primary care to learn how to insert intrauterine contraceptives. They're going to be very helpful for helping patients have only planned pregnancies, which is our goal. Whatever, philosophy you have about how to deal with an unplanned pregnancy, that's our goal for all of us. So I would just really encourage you to learn. Reach out to the manufacturer. They will train you. They'll hook you up with a clinician that can teach you hands-on. And I don't think it should just be reserved for OBGYN. The patient could get pregnant in the time they get referred by you to seeing the OBGYN.
Yeah. So we want to be timely about that.
Yeah,
no,
be
I appreciate
really
that.
Careful.
Yep. Don't worry about that alarm. We're all living in our
I didn't
real
want to
lives.
miss this. I didn't want to miss my Q&A. It happened twice.
I love it.
Oh, sorry.
No, that was perfect. Keeping it real here. So one of the things we had a question specifically to PCOS, and it all leads to infertility, hyperinsulinemia. What do you use for women who are not able to take metformin? Let's talk about the metformin a little bit, because the thoughts have changed a little bit with that.
The reason would be, I don't know what the reason is that the patient couldn't take metformin or can't. Are they trying to get pregnant?
Well, it could be kidney stones. So metformin can, because it's cleared through the kidneys.
So I don't know the context. I don't know the context of this patient. That's just more what I'm saying. Okay. So what's the question again, Terry?
Okay. So PCO is exacerbated. They were started on Provera monthly, increased abdominal girth and weight. It all led to infertility, hyperinsulinemia. What do you use for women who are not able to take metformin because they had kidney stones for multiple years during fertility treatments?
So lifestyle and even combination hormonal contraceptives get at the insulin resistance. It's just in a different way. So if you drive up sex hormone binding globulin levels, that drives down testosterone and that improves insulin resistance. So it's not something a lot of clinicians are aware of, but it can be extremely effective. So that would be another possibility. GLP-1 agents, we're becoming much more versant in utilizing those. Could be a possibility, but they are not established to be safe in pregnancy. So I would prefer that if you're thinking about those options, refer to endocrinology and have them prescribe the agents, because it's just too much liability not knowing.
Okay. No, I think that's really good advice. Thank you. Yeah. One of our participants asked about Mirena IUD.
Mirena for moms, Kylena for kids is how I remember it.
Oh, I like that. Does it help also with the cancer and PCOS risk in patients?
It does, because it protects the uterine lining by providing the levonorgestrel that acts like a natural progesterone. It is a synthetic progestin. Both are under the umbrella of progestogens. So yes, it is very helpful.
Okay. I appreciate that. One other recommendation, do you recommend using opposing progesterone when you give prescribed vaginal estrogen in patients?
Not needed. Not needed. So what we know now with the most recent research is that the systemic levels are so negligible, they're probably not an issue, because our best research now has indicated that there's no increased risk of breast cancer, uterine cancer, or cardiovascular disease with patients using vaginal estrogen. So it's kind of settled that question, which is really helpful because patients are still scared about using vaginal estrogen. And most patients that use vaginal estrogen can get away with just a small amount applied to the vaginal introitus. And they don't have to use intravaginal unless they're having deep discomfort or they're having abnormal vaginal discharge. So that's also really helpful.
Okay. Great. Have you heard of the supplement Ovasitol?
Vasitol sounds like
Ovasitol. OVASITOL.
Is it over the counter?
Yes, it's an over the counter.
All right. So what I say about over the counter preparations is they're unregulated by the FDA. So I do not recommend over the counter potential hormones because we have no idea about their safety, no idea about their effectiveness. They can make any claim they want. I do not like patients taking over-the-counter, in quotes, hormone preparations. I think they're very, very risky. And remember, if you have a postmenopausal woman who's thinking about an over-the-counter hormone option, many women entering menopause already have cardiovascular disease. So you know they're going to have some negative outcomes, and you don't want to be prescribing over the counter thinking maybe it's safer. So educate your patients. They're regulated in Germany, but they're not regulated in this country. And they scare me because of that.
I appreciate that. Thank you for saying that.
Yeah, no problem.
I thank you for being here yet again, third talk during this conference. It's been so great to have you
I'm
with
thrilled
us.
for everyone's interest in polycystic ovary syndrome.
Yeah.
It really needs a new term because it's, that's just the victim. The ovary is the victim. It's a much more complex pathophysiology and condition. So we're learning more, and it's going to be exciting to just track the research over the next few years.
Yeah, it'll be good to see where it goes. If you'll keep track of it, we'll have you back
I sure
to
will
talk about it again in the future. Thank you for being here.